Good afternoon, everyone. So first of all, at the outset, I would like to thank Nilesh sir, Pankaj sir, Harsh sir, and Endocrine Society of Rajkot for inviting me here to discuss this very important topic. Now, more than a century ago, we moved on from photograph to videograph. And as we all know, photograph and videos today both have their own individual importance. Similarly, glucometer readings, SMBG monitoring is the photographs in diabetes, and CGM is the videography of diabetes. So what exactly is CGM? CGM is monitoring the interstitial glucose level, while with glucometer you are monitoring the capillary glucose values. So as the blood moves on from the capillary into the interstitium, in the capillary you will be monitoring it with the glucometer. With the CGM you will be monitoring it when it is reaching it below the skin. So that is why there is always a physiological lag, and the CGM values of blood glucose readings will slightly lag behind the glucometer readings. So now where is it essential? So if we look at the triangle of diabetes care, we want that the patient's overall glucose value should be better. But this glucose value should be achieved with a low risk of hypoglycemia, and there should be less variability. So these are where the limitations of HbA1c come into the picture. We've already had a talk on what are the limitations of HbA1c in Indian patients. Along with this, if we look at the percentage of patients reaching their HbA1c targets, they are still very minimal. And majority of the diabetes centers worldwide, only 60 to 70% of patients, even with good specialized care, are able to reach their HbA1c targets. Beyond that, there is also the concept of glycemic variability. So if we look at here, there are 3 patients, all have HbA1c of 7%. But if we look at example number 3, 100% of their patients' glucose values are staying between 70 to 180, while for patient 1, it is only 18%. So now whether this is harmful to the patient or not, that data we have from the DEVOTE study. And what this DEVOTE study has shown is that not only is your average glucose important, because your average glucose can be 100 if one value of your sugar is 40 and the other value is 200. What is also important is overall how good your glucose readings are staying. So if the variability is low, your all-cause mortality is also lesser. If your variability is high, your all-cause mortality is also increasing. Along with that, in terms of HbA1c, both at HbA1c of less than 6% and HbA1c of more than 9%, the risk of hypoglycemia is very high. And as we all know from follow-up of all our patients, for patients, hypoglycemia can be a life threat. The patients can lose their lives if they have hypoglycemia as well. So there are 3 types of CGM. We are not here to discuss the various types of CGM. We are here to discuss what we as clinicians need to do once the patient comes to you with the report. The standardized reporting for CGMS data is through AGP monitoring, and the first thing which you need to check when you are checking the AGP monitoring is the patient's name and the sensor number, because these sensors are often applied by other people. They are not directly applied by the clinicians, and very commonly there can be fault in entering the name of the patient. So first thing, check the patient's name and check the patient's sensor number. Sensor number is mentioned on the sensor itself. After that, you need to look at the various metrics. So now what are the metrics you need to look at? So first is the number of days the patient has worn the CGM. So if the number of days the patient has worn the CGM is less than 70%, and if the percentage of active time is less than 70%, then that CGM reporting is not likely to be reliable. Then we need to look at what is the mean glucose and the GMI. So that is similar to our HbA1c, but HbA1c is average of the last 3 months of glucose, while this is the average of the last 15 days of glucose. Next, we need to look at the variability. Now, we have already discussed that a patient having a very high and very low glucose value will still have a normal average. But what is the variability? And this variability, we need to target that it should be below 36%. And then we need to look at the time above range, time in range, and the time below range. So these are the standardized targets. You want that for a patient to achieve a target HbA1c of 7%, and for the patient to call it as a good glucose control, you need that the patient's time in range, that is the time that the patient is staying between 70 to 180 should be more than 70%. This should be associated with a low risk of hypoglycemia. So the time below range should be overall less than 4% and the time above range should be less than 25%. And then there are specialized settings as well in older individuals. When we relax their glucose targets, you can relax the time in range target to less than 50%. In pregnancy, in individuals with gestational diabetes, you will target as high as 90% time in range. And each 10% improvement in time in range, so time in range going from 70 to 80% will improve the patient's HbA1c by 0.8%. Now next is the glucose variability. So this is the graph which we will see when the patient comes to you with the CGMS report. So now what is the interpretation of this graph? What this is basically showing is that the median value, so this black line is the patient's average glucose value throughout when the patient was wearing that sensor at different points of time. 25% above and 25% below. So this is the patient's 25th centile line and this is the patient's 75th centile line. And then last is the 10% above and 10% below. So 10th centile line and the 90th centile line. So wider the graph, more is the variability of the patient. So you want that the patient should have a narrow graph and that narrow graph should be staying between 70 to 180. So here why we are using median and not mean, because mean values will change with just one alteration of glucose value, while median it is more indicative of the average value of the patient. And why we are applying it for 14 days. So we are applying it for 14 days because for 14 days there is evidence that if the patient has a sensor for 14 days, then that is able to predict the patient's next 3 to 6 months of glucose values. So now this was the overall, the top line reading of the various parameters. Now what is most important, especially when you are titrating for the patient, is what is the patient's individual curves and how will you be interpreting the individual curves of the patient. So now while the metric should be followed up only after the 14 days when the patient has completely utilized the sensor, now more and more evidence suggests that you can be monitoring and you can be titrating it every 3 to 5 days. So how you should be titrating the patient? So for first thing, you need to look at the curves in terms of the various time blocks. So anytime you get the patient's total throughout the daily curve, you should be differentiating it into overnight and daytime curve. And in overnight and daytime curve, you should be marking down when the patient is taking the meal and when the patient is taking insulin, and then you need to divide it further into fasting, after breakfast, before lunch, after lunch, before dinner and after dinner value. Now with the glucometer you will only get the point estimate of glucose, but here with the CGM data you will be also be able to know what is the variability, how wide is the curve of the patient and what is the exposure, what is the absolute value of glucose and the absolute change in the glucose parameters. Now simply how you should be monitoring them is that first you will be looking only at the overnight glucose readings, and in the overnight glucose readings, if the patient is on insulin, you will be using it to determine whether the patient's basal insulin is correct or not. So if the patient's basal insulin dose is correct, then the graph will be completely flat overnight when the patient is sleeping. If the patient's basal insulin dose is too low, then the graph will be going up. And if the patient's basal insulin is too high, then the graph will be going slowly downwards. Now, along with this, we already had a discussion in the previous session on Somogyi phenomenon and Dawn phenomenon, and this is where the CGM shines. So this is one of my patients. So this patient was receiving 50 units of Tresiba, 50 units of basal insulin, and along with that the patient was receiving 10, 10 and 10 units of bolus insulin. So at outset you can suspect that the patient is having over basalization. The patient's basal insulin, total basal insulin which the patient is receiving is more than what is the total of the bolus which the patient is receiving. But what was happening was that the physician who was titrating for the patient, because the patient fasting glucose was staying between 180 to 190, every 3 days they were going on and increasing the dose. So when the CGMS was applied, we could check that from 2 a.m. to 3 a.m. the patient was having glucose values which were ranging between 60 to 70, and after that the patient was having a spike. And as we stepwise, we reduce the dose of basal insulin, and along with that, for this patient, there was a sudden dip in the curve. So we actually reduced the pre-dinner insulin as well, and the patient's pattern was corrected. And with reduction in the dose of basal insulin, the patient's fasting glucose was corrected. And now, as we had already discussed, what is much more common is dawn phenomena. So anytime when you are rising up, with your when you are waking up, along with your waking up, your hormone systems are also waking up. So there is increase in cortisol, there is increase in growth hormone, and what all of these hormones do is that in the early morning, beyond 4 am, there is a rise in glucose. So now, how can you tackle this rise in glucose? So this is called as dawn phenomena. So the first thing which we need to be sure of is that anytime the patient is on glargine, while we consider glargine as a once daily insulin, its average duration of action is 18 to 20 hours. So if the patient is receiving glargine in the morning, we should be shifting it to night. After that, you can try to increase the basal dose by 20%, and then look whether the patient's hypoglycemia, without going into hypoglycemia, whether there is correction of the fasting hyperglycemia as well. You can add a small dose of metformin at night, and then this is not recommended, but what is used by a lot of clinicians is that you can ask the patient to go for a walk after dinner. So after dinner, if the patient goes for a proper aerobic activity, then after 4 hours of aerobic activity, we'll see subsequently there is some reduction in glucose, and then that can help to get the dawn phenomena in check. So this was the overnight tracing. So after you have looked at the overnight tracing, you have corrected for hypoglycemia. The next thing which you need to check is the patient's meal time, throughout the day, what is happening to the CGMS data. So first thing is that you should not be interpreting the CGMS at baseline. Anytime you are interpreting, you should be asking the patient 2 questions. What meal you have taken and when have you taken the meal. So only if you know whether when the patient has taken the meal, you can interpret how many hours after the patient is having the change in glucose value. And if the patient is on insulin, you need to also mark when the patient has received insulin. So this is the meal time insulin. So this is how you would mark them. The patient is having some glycemic excursion. You have monitored when the patient had taken the meal and when the patient had taken the insulin. And overall, first thing which you need to look for is that if the patient's insulin dosing is proper, or if the patient's OHA dosing is proper, within 4 hours, the glucose value should come back to baseline. So here the patient has taken meal at 6 p.m. and by 10 p.m. the patient's glucose value is back to baseline. So now if you have given too low a dose of insulin, there will be increase after 4 hours as well. If you have given too high a dose of insulin, then there will be dip post the meal of the patient, especially at 4-hour interval. So this is where you need to be evaluating, you need to be checking for the patient. Now first thing which you need to correct for is what is the timing of the insulin. So if you have given the insulin too late, so here the patient had taken meal at 5 p.m., took the insulin at 5:30, and the patient had a dip in blood glucose. So first thing, correct the patient's insulin timing. After you have corrected for the patient's insulin timing, you need to ideally based on CGM. So in Western countries where CGM is available free of cost in insurance, you can calculate individually the patient's dose of bolus insulin based on the pre-meal RBS with the correction of our insulin sensitivity, then based on what the patient is going to eat, based on the patient's insulin carbohydrate ratio, and how quickly the CGMS is changing. So then on the CGMS, we have this trend arrows, and for trend arrows, when it is going up, it means that the glucose is rising by more than 2 milligram per deciliter per minute. You need to increase the dose by 20%, and similarly, if it is going down, you need to decrease by 20%. So this is ideal, which is not very practicable in India, where the patient has to pay out of pocket for the CGMS. So here what we need are common guidelines, and the very common guideline, first common guideline is within 2 hours, the glucose value increase from the baseline should be within 80 milligram per deciliter, and within 4 hours, the glucose value should be coming back to the baseline. If these 2 targets the patient is achieving, then the bolus insulin dose you are giving is correct for that meal for the patient. So the data, now if this is the curve you are seeing for the patient, so here you can see that the average is good, but the patient's variability is very, very high. So the most common reason, so this is one of the patients, the patient is taking a different meal every day. The patient has taken bread pakoda one day, the patient has taken samosa the other day, and this is why the variability is very high. So in these subset of patients, what you need to educate is that these are the carbohydrates you are taking. you need to, at least when we are titrating, you need to be on a stable carbohydrate with each meal. And after we have titrated, when you are taking a high carbohydrate containing meal, you can take a higher dose of insulin. If you are taking a low carbohydrate containing meal, you should be taking a lower dose of insulin. So this is how we can tackle for the variability. So now this is one of my patients. So the patient was on a stable dose of basal bolus insulin, but every time the patient's pre-lunch value was normal, pre-dinner value was very high, and we were increasing the dose of pre-lunch blood glucose. So we advise the patient to go for CGM, and of course you can do this with self-monitoring of blood glucose as well. You can ask the patient to check the blood glucose value before snacking, after snacking, but પછી patient એક દિવસમાં કેટલી વાર sugar માપે. So we advise the patient to go for CGMS, and this patient was having the classic pattern. At 6 p.m. the patient was taking some snacks, and this was causing the rise in blood glucose. And now when should you be giving insulin when the patient is taking snack? Just rise in glucose is not enough to give the patient additional dose of insulin. After the rise in blood glucose, within 4 hours, the glucose value should not be coming back to baseline. Because anytime you eat, there will be some increase in blood glucose. That increase in blood glucose is not pathological. But if after increase in blood glucose, within 2 hours, it is not coming within 80 milligram per deciliter, and within 4 hours, it is not coming back to the baseline, that is when you need to be adding insulin for the patient. So for this patient, before every snack, we added 3 units of insulin, and now that patient has HbA1c of 6.7%. Now, even for exercise, again, if you look at the guidelines, you can do self-monitoring of blood glucose. You can check it before exercise, you can check it after exercise, you can check it 4 hours after exercise. But again, the question comes as to how frequently are you going to monitor the blood glucose, and whether with every bout of exercise are you going to be monitoring the blood glucose. So this is again where CGM comes into the picture. So what we see is for every mild to moderate aerobic exercise, there is an initial rise in blood glucose, and the blood glucose comes back to baseline. Now, if the patient has high intensity exercise, there is an initial spike in blood glucose, and the blood glucose goes below the baseline. So this is where you can add a short acting bolus of insulin, or you can ask the patient to take to do exercise after their meals and to do it with a slightly higher dose of insulin. So looking at a few cases, a 14-year-old female type 1 diabetic on Lantus 30, insulin 16, 16, 14, came with this pattern. So now we need to now divide what is the patient's overnight glucose, pre-breakfast, post-breakfast, pre-lunch and post-lunch, and then you need to be determining. So this patient was having a nighttime hypoglycemia. We reduced the dose of patient's basal insulin. The patient was having post-breakfast hyperglycemia. We increased the dose of patient's pre-breakfast insulin, and with this the patient achieved a good glycemic control. So this is a patient on premix insulin. We see this day in and day out. So this is the patient's glycemic pattern. The patient is having very high glucose variability. The patient is having hypoglycemia as well, and the patient is having hyperglycemia as well. And this is where premix insulin, where you cannot titrate the long-acting and short-acting insulin separately, becomes a problem, because when you try to increase the dose, the hypoglycemia will increase, and when you try to reduce the dose, the hyperglycemia is increased. So that is when you can shift the patient to bolus insulin. So now when you are interpreting CGM, what is very important is that you should not be overreacting to single day spikes. The patient has gone outside, the patient has some increase in blood glucose, you will increase the dose of insulin by 6. Next day the patient will take less meal and the patient will have hypoglycemia. So at least wait for an average of 2 to 3 days before you change the dose of insulin. And so the take home message is that CGM gives you valuable information over and above HbA1c, and patterns reveal what the averages hide. Thank you very much.